options here. In your package, I think I've given you 2 depression screening scales. Well, 1 depression screening scale and one magnitude scale. The Patient Health Questionnaire 9, the PHQ-9, this one here. So the PHQ-9 is actually a depression screening tool. The items on that scale are taken almost verbatim from the DSM-4 criteria for a depressive disorder. You'll take a look at the items there, and if you look at the bottom, it tells you actually how to score this. In fact, you can go and Google this tool, and I think one of the first hits you get is where people, like just the lay public, can go and complete it themselves. And they can score it themselves and say, I might be depressed. So it's not as though we're hiding anything here. Okay? This is publicly available. A couple things, though. First of all, you look at that last question. Thoughts that you would be better off dead or of hurting yourself somehow. Are we ready to deal with that? It's not uncommon. I've had at least 3 patients in my career say they were defenses. You'd better make sure you know how to address that if you're going to apply some of these things. You may decide, on the other hand, that you just want to stay away. Perhaps you are familiar with the items on the scale. And if a patient starts talking and sort of making comments that sound familiar to that scale, maybe that flicks a little yellow flag in your head. And you think, oh, you know what, actually, I think we'd better have you seen by so-and-so. Like maybe that's as far as we want to go, and that's perfectly fine. I do encourage, I do think it's definitely appropriate, and I think there's little discussion to be had here, that we should know what the signs are. Okay? Whether you want to formally administer a tool to screen for it ultimately is up to you. It's your own level of comfort, whether you feel like you can score it and interpret it properly, whether you feel like you've got the means to address it should it come up. Incidentally, protocol for suicidal ideation. If the patient says something like, sometimes I feel like I'd be better off dead, that's usually something that you need to follow up with. You would say, would you like me to talk to your doctor about this, or would you like to talk to your doctor about this? Sometimes you may decide to call the doctor with their permission. Maybe there's a counselor we've got, and I think we'll speak with this counselor. Maybe you're in a nice multidisciplinary clinic or something like that, or you know of a good counselor, psychologist, psychiatrist somewhere around that you can refer them to. Not necessarily a medical emergency, but something that you should follow up with. You may even decide to say, no, I'll give you a ring tomorrow to see how you feel. Okay. If, on the other hand, they say, I've got a gun in the glove box in my car, I'm going to go out to the parking lot and shoot myself, that's a medical emergency. And that's one where you need to call emergency services. Okay? Don't let them leave. Call the services. They're a threat to themselves. And occasionally the public, actually. One guy I had said he was going to drive his car in oncoming traffic. Well, you're not leaving. I was fortunate that I worked in a hospital at the time, and emergency was right across the hall, so I said, let's go. So anyway, having a plan for that, I think, is of utmost importance. Now, I think I also gave you the HADS. Is that the one over? Yes. So I also gave you the hospital anxiety and depression scale. Now that one is actually a bit more, what's the word, gentle? Not quite as direct. The HADS actually is meant to be a tool to essentially quantify symptoms, depressive symptoms and anxiety symptoms. And if you take a look at those questions, you'll notice right off the bat, it's 14 questions long. Each one, vice versa, switches between depression and anxiety, okay? All the way down. Some of them are reverse scale, so it becomes a little bit of a challenge to score them. So some of them are worded in the positive, which is actually really nice. That's one thing. You look, all the scales we've looked at so far are really negative. I'll be honest with you, as someone who works with these scales a lot, there are days that I feel kind of bummed out. Reading these scales, it's the worst thing that ever happened to me, I can't go on. It is the worst thing that ever happened. So it's nice actually that on the HADS, some of these are actually positively worded. So it's not always doom and gloom. It's not as useful a tool for screening for depression, but it could give you a sense of whether they appear to be endorsing a lot of depression-like symptoms. I'm not saying I'm screening for anything, but man, they're really scoring high on this. I think it might be worthwhile having them talk to somebody, or suggesting that they talk to somebody, or the anxiety side for that matter. One thing about the HADS, if there was a knock against it for use in this population, is that there are a couple of items on there that are potentially confounded by pain. So there's one item, something like I can still sit and feel at ease, relax and feel at ease, something like that. Which, I mean, if you've got low back pain or something, chances are you can't just sit and feel at ease. So that may not be a sign of anxiety, that may be a sign of low back pain. So there's a bit, if there was a knock about it, on it, it would be that. But, the HADS might be one of those tools if you were thinking of maybe starting to introduce some of this more sort of emotional type of measurement into your clinic. And again, completely up to you. I'm not sitting here saying you should or you shouldn't. But if you're going to do that, you might choose something like this, which is a little bit more gentle than going right into a depression screening tool, which I think, again, you really need to think hard about what you're going to do with that. Okay. I've given a couple of other ones here that you'll hear about. The impact of events scale is a PTSD, well, actually that's not true, a post-traumatic stress symptoms tool rather than post-traumatic stress disorder. There are a couple of PTSD screening tools out there as well. For those who work a lot in trauma rehab, again, it's a consideration. It's something that you might want to think about, become familiar with the scale. There's a couple of them out there, the PTSD checklist, the PTSD diagnosis scale. You can go and you can find these online and you can learn about them and you can learn how to apply them and how to interpret them. And indeed, PTSD probably occurs in somewhere around 20% of people following a motor vehicle accident, regardless of how intense that accident actually was. 20% is not a small number. So if you see a lot of MVAs in your practice, I think there's an argument there for potentially screening for this, especially in people who aren't getting better. But again, I will say one more time, be familiar with them. I would in fact even encourage you to talk to a psychologist maybe before you go ahead and do this. I know the psychology colleague that I've had a chance to speak with in the past has said if you go and administer this too early, post-injury, you may in fact cause post-traumatic stress symptoms by asking them to reflect on these items. So hold off on it for a month kind of thing. So just knowing things like that, I think are going to be important. So I'm not saying go ahead and apply these, but anyway, these are ideas that you may want to think about in your practice, especially if you see a lot of complex chronic pain problems. You know that depression is an issue, PTSD may be an issue, previous interpersonal violence is possibly an issue. We don't need to stick our heads in the sand and pretend that it doesn't exist, but we need to be very careful with how we go about identifying it. I do think it's important to talk about. Mental health is a real thing. We don't need to shy away from it. We just need to be careful with it. So, yeah.
Are there any legal implications about screening and not referring appropriately?
I would think so.
Yeah.
So the question is, are there legal implications of screening and not referring appropriately? And I would say, here's the situation. You go and you apply a depression screen, your patient endorses suicidal ideation, you don't know what to do about it, they go home and kill themselves, and you've got that sitting on the chart, I would say you're in trouble. Simple as that. Occasionally I've been asked to provide sort of expert opinion on cases, disciplinary cases for the College of Physical Therapists at least. And on one or two occasions, I would say there were situations where the physio probably went a bit too far down the rabbit hole on the psychology side of things. We needn't necessarily fear screening. And this is something that actually I would almost like to see in sort of professional education, so at the MPT level, or the MOT, right? Anyway, at the entry practice level, I would like to see people perhaps introduce this idea of psychopathology screening, because mental health is such an important issue. But I just hope we do it properly.